Assalamu alaikum, everyone. My name is Tasneem Al-Ibrahim. I'm a fourth-year medical student, and today we're going to be solving some endocrine and reproductive practice questions. Since this session is recorded, what we're going to do is that I'm going to display a question and then give you a few seconds to pause, answer the question, and then I'll show the answer and discuss it with you, okay? And if you have any questions or concerns, please reach out to me anytime, especially since this is recorded. With that being said, let's get started. Bismillah. Okay. We're going to start with endocrine questions, and then we will move on to repro questions. So here's the first question. I'll give you a few seconds to pause and solve the question. Now let's look at the answer. So if you answered B, elevated serum TSH concentration, you are correct. Let's go through this scenario. So we have a 16-year-old female, and her main complaint is that she has 6 months of menstrual cramps, which is dysmenorrhea, heavy menstrual flow, menorrhagia, and fatigue. She's gained weight during this period. And what else stands out? She has scleroderma with episodic pallor of her fingertips. So this tells you she has something most likely autoimmune. Her BMI is 30, so she's obese, and her vital signs show that she has bradycardia. And then you go to her physical exam. She has a puffy face with telangiectasias and thinning of the eyebrows, and she has hyporeflexia. Remember, we have deep tendon reflexes graded from 0 to 4. 0 is no reflexes, 4 is hyporeflexic, 2 is normal, and 1 would then obviously be hyporeflexic. Everything else was fine with this patient. So this is a clear case of hypothyroidism, right? Hypothyroidism, you have too little thyroid hormone in your body. Thyroid hormone is all about metabolism. And so everything pretty much slows down. You start gaining weight, you have constipation, you feel cold, you might even feel depressed. The deep tendon reflexes are impacted, her heart is impacted, her menstrual cycle also is impacted. So the first thing you want to do when you deal with any thyroid disorder is measure TSH. That's the first step. After you measure TSH, you then move on to measuring free T4, free T3, and then you might opt for some imaging, plus minus antibodies, etc. Now, there is a point that I wanted to, So some of you may have chosen E, midnight serum cortisol concentration, which is actually a great guess, because the scenario does kind of go with Cushing, right? But it does not explain the hyporeflexia and the bradycardia, right? And so maybe this would be on your differentials after you rule out involvement of the thyroid gland. There's another point here, which I don't think you guys need to know this, but we will be sort of touching upon this point later on in repro. So I thought it was worth mentioning. So here in G, you can see elevated serum LH-FSH ratio. FSH is the hormone that comes out of the pituitary and it's high around day 3 to 5 of menses. And what it's doing is just recruiting follicles, right? Because it wants to feed those follicles so that one of them can come out and be ready for ovulation around day 14, right? The LH, on the other hand, we have an LH surge, if you recall, right before ovulation, because it's the hormone that induces ovulation. Now, when we say we have an elevated serum LH to FSH ratio, we're seeing the hormone that causes ovulation is much higher than the hormone that recruits follicles, and they are both a bit high, right? And so what causes this? You might imagine something that, a condition where the patient does not have ovulation, right? And so the classic condition that has elevated serum LH-FSH ratio, and the classic condition where we test in the clinic specifically for LH is PCOS, okay? PCOS is when you have this, hold on a minute. Okay, you have your ovary, and there's just a bunch of cysts on the outside like this, just a ton of cysts like this, and they are all not that big, and they are all just cystic, and most of the time you are not ovulating. These patients are not ovulating. Sometimes they do, but for the most part, they're not. And so they have an elevated LH and FSH, but for the most part, LH. And then H also goes with this, right? They have elevated androgen concentration, so you might have elevated testosterone in these patients. So I just wanted to touch upon this part. And yeah, I think we can move on now. Here's the next question. Take a few seconds to solve this, or you know, as much as you want, but I mean, now I'll show the answer. So the answer is, again, hypothyroidism, but what stands out in this question, you may have already noticed, is that the patient has hyperprolactinemia and galactorrhea. So clinical evidence of this hyperprolactinemia. And so the learning point is, we have the thyroid gland, and the thyroid gland, unfortunately, is not secreting enough thyroid hormone. Who detects this? The hypothalamus detects this. And the hypothalamus, remember, secretes a hormone called thyrotropin-releasing hormone. Thyrotropin-releasing hormone is supposed to go to the pituitary and make it secrete TSH, right? And then TSH goes to the thyroid gland, and you get the rest of the story, right? Now, what happens sometimes is that this thyrotropin-releasing hormone in the hypothalamus goes and makes the pituitary secrete prolactin. And so we have hyperprolactinemia that is clinically evident. Now, some of you may have been really smart and you said, okay, but what about C? And you might know that fluoxetine is actually a dopamine antagonist. And you know from your lectures that dopamine antagonizes prolactin, right? It pretty much stops its secretion. So if I antagonize the antagonizer, then the one being antagonized is not being antagonized. In other words, if I remove dopamine's inhibition of prolactin, you know, maybe a visual would be nicer. So this is dopamine, this is prolactin. Usually dopamine goes to prolactin and says, stop. But if I stop this, you stop the stopper, then the one being stopped is not stopped. And so you might think that, okay, if I take a dopamine antagonist, I'll have hyperprolactinemia. Excellent thought. Actually, you are correct. But you wouldn't have prolactin levels that reach this much. And you also wouldn't have, most importantly, clinically evident hyperprolactinemia, okay? And that is why hypothyroidism is the most correct answer in this scenario. Okay, let's move on to the next question. Here's the next question. Give you a few seconds to pause, read it, solve it. So, if you chose E, hyperparathyroidism, you are correct. What's going on with this patient is 41-year-old, and if you remember from GI, she clearly has pancreatitis, right? Abdominal pain radiates to the back, lipase is high, ultrasonography shows you peripancreatic edematous swelling. This is pancreatitis. Now, another thing they found when doing ultrasound are 2 millimeter calcifications in the right renal parenchyma. This tells you that she has most likely a stone. And then you look at her labs, and oh my goodness, she has hypercalcemia and hypophosphatemia. This is clearly the doing of PTH. And so this patient most likely has primary hyperparathyroidism. Now, how does this scenario all go together anyway? What started? Most likely she has hyperparathyroidism and she has hypercalcemia. And if you remember from GI, one of the causes of pancreatitis is hypercalcemia. So this is most likely what happened in this patient. Now you may have said, okay, what about D? And excellent thinking. But let's read D very carefully. Familial, hypocalciuric, hypercalcemia. Hypercalcemia, check. Hypocalciuric, uncheck. Why? Because it's clearly hypocalciuric, which means we don't have much calcium in the urine. So these wouldn't add up together, right? The calcifications in the renal parenchyma would not add up to this hypocalciuric situation. And also, not to mention, Yani, familial hypocalciuric hypercalcemia is usually asymptomatic. And so this patient most likely has hyperparathyroidism, not hypocalciuric hypercalcemia. next question. I think this will be easy. Shall we see the answer? If you chose D, excellent, you are correct. This patient has Sheehan syndrome, right? And so this is, this is the textbook, the all the time board question scenario that will always come. Woman went, gave birth, and then after giving birth, either they tell you it was a home birth, so you don't know how much blood she lost, or she lost a ton of blood when she was giving birth, and then now she, for example, cannot breastfeed or has some kind of hypopituitary symptom. In this case, look here, hypoprolactinemia, and look at low blood pressure and hypoglycemia. This is very low finger stick blood glucose concentration, and so most likely this is adrenal insufficiency symptoms, and so pituitary ischemia. Now, why is a very good question. So basically, when women are pregnant, their pituitary, specifically the lactotrophs, undergo hyperplasia. Remember how lactotrophs secrete prolactin, and so they give birth, they lose blood, and this area, the arteries that are supplying the pituitary are particularly low blood pressure. They're low. The blood pressure is low there, and so when you lose blood, the blood pressure drops even more to the point where sometimes you can even have ischemia of some parts of the pituitary, especially the parts that decided to grow, aka the lactotrophs. So yeah, I think inshallah you should not get this wrong on the exam, okay? It's very high yield. Here's the next question. I shall show the answer now. If you chose C, you are correct. This is 21-hydroxylase deficiency, and it is not so classic, is it? So basically, I think the biggest telltale should be the elevated serum 17-hydroxyprogesterone. Now, why is this patient presenting like this? Why is he 13? Why is he not just like a baby? So this is non-classic 21 beta hydroxylase deficiency, okay? We have a classic type and we have a non-classic congenital adrenal hyperplasia. In this case, it's non-classic. And so the classical symptoms of hyperkalemia and metabolic acidosis and all of these, they're not usually present. Instead, we have either precocious puberty, or for example, in women, you might have irregular menses. So you can see here, he's 13, he's already getting acne, he's already shaving, he already has a Tanner 4 and Tanner 5. That's a lot for just a young boy. He had pubic hair growth at age 8, and his labs are the biggest telltale, right? And so this is 21-hydroxylase deficiency. 11-beta hydroxylase deficiency so here we have deoxycortisone being low, it would be high, right? And they would have elevated DHEAS, but it would be a little bit higher here, much higher. Here it's a little bit high, but not too high. But in 11-beta hydroxylase deficiency, it would be much, much higher than this. And we have a very nice graph over here that kind of shows you the kind of patients that you will get if you become an endocrinologist with these kind of patients. So you might get a very young patient, just born, atypical genitalia. You have to maybe resuscitate this patient and give him all kinds of things because he has a salt wasting classic adrenal hyperplasia. Meanwhile, the rest of your patients, they'll be okay, but some of them might have virilization at a very young age. Some of them might come to you and they're much older with irregular menses or amenorrhea even, hirsutism and fertility issues. And so the point here is just to tell you that congenital adrenal hyperplasia is kind of a spectrum. Some of them have it much worse than others. And the picture in boys would be precocious puberty, picturing girls, can be precocious puberty, can be irregular menses, most likely, and virilization. So hirsutism, for example. Here's the next question. So this is a very classic, board classic question. And the answer is D, impaired migration of GnRH neurons. This patient has Coleman syndrome. Coleman syndrome, boy, hypogonadism, anosmia. Done. Why? Basically, there's something. So when the brain is developing, there's something called the olfactory placode. Just imagine that you have this, half of it has one type of neurons, the other has a different type. The first type will migrate to form the olfactory bulb. Okay, here's a nose. It doesn't look like that. The olfactory bulb is a bit behind, but just for the visual. The second one has gonadotropes. And these gonadotropes are supposed to migrate and eventually secrete LH and FSH and do their thing, right? Now, when this does not form well, you do not have the olfactory bulb, you do not have gonadotropes, so you end up with hypogonadism, and you end up with anosmia. Okay, it's hypogonadotropic hypogonadism, because gonadotropic, because we have gonadotropes that are missing, they're not there. And so this is what the usual clinical picture is. He's unable to smell. He had a bilateral oculoplexy because hypogonadotropic hypogonadism, and they also have delayed puberty, right? So look here, he's so short. And sparse axillary hair and pubic hair, stage 1 genitals, that's basically delayed puberty. And so there is impaired migration of these GnRH hormones, and so they're not there. Classic board question. Here's the next question. Okay, let's see the answer. If you chose E, desmopressin, excellent, you're correct. What does this patient have? If you said diabetes insipidus, you are correct. And this is a very classic scenario as well. Patient had a transsphenoidal pituitary surgery. They removed part of her pituitary, in this case because she has a non-functional adenoma. And after that, she keeps going to the bathroom. She has a very large amount of urine output, very thirsty, and she has a lot of sodium in her. What was the name of a lot of sodium? Hypernatremia. But it's not a lot of hypernatremia, it's just because she's losing a lot of fluid, right? Why? Diabetes insipidus. What is diabetes insipidus? It's when your ADH is not working for some reason. It can be central, it can be nephrogenic. Either it's not being secreted or the receptors in the kidney aren't working. In this case, it's clearly central, diabetes insipidus. And what do you do if someone doesn't have ADH? You give them ADH. So you give them desmopressin. This is basically the ADH analog, and hopefully their symptoms will become much, much better, and this patient will be very thankful for your help. So let's go to the next question. Here we have a 34-year-old man. Okay. So we see the answer. If you chose B, you are correct. This is a very classic presentation of hyperprolactinemia in a male patient. So they will usually have difficulties achieving erections, and here he also has a mass effect. And the most common pituitary adenoma is hyperprolactinemia, or from the lactotrophs. Here's the next question. This is very similar to one that you solved earlier. So the answer is E. Again, this is a case of non-classic congenital adrenal hyperplasia, and this is basically the person that came to you. But I wanted to tie this in with repro real quick. So actually, if this patient came to the clinic, I would imagine that they would come to the OBGYN clinic. And the doctors are going to suspect polycystic ovary syndrome, right? Because excessive facial hair, hyperandrogenemia, irregular menstrual cycles, hirsutism, normal genitalia, it all goes with PCOS, okay? Now, what kind of tells you, okay, maybe this might not be PCOS, her BMI is normal, and of course, it's the 17-hydroxyprogesterone. Now, there is something to note. There are two kinds of PCOS. PCOS with obese patients and PCOS with patients who are not obese, sometimes even underweight. So this does not exclude PCOS, but I think that this might have been the clue to the physicians there to just test and see if maybe this patient has congenital adrenal hyperplasia, and it turns out that she did in fact have congenital adrenal hyperplasia. So good learning point here, I thought. And yeah, that's it for this question. Let's move on to the next. Okay, let's see the answer. So if you chose E, you are correct. Now, I admit this question is a bit tricky, and you definitely will get much easier questions on this topic than this. But I thought it would be just good for you guys to kind of see the association from a different point of view than the one usually presented. But trust me, it will be much, much easier in the exam. So what's going on with this patient, first of all? He has mucosal neuromas, which is in what kind of syndrome? Or what kind of, this is in multiple endocrine neoplasia, specifically type 2B, okay? So we have type 1, type 2A, and type 2B. Type 1 is the one with the 3Ps, hyperparathyroidism, pituitary tumors, and pancreatic tumors. Type 2A is medullary, type 2A and type 2B both have medullary thyroid cancer. So this should be medullary. And then type 2A and type 2B both have pheochromocytoma, but then they differ with the third one. So type 2A has hyperparathyroidism, type 2B has mucosal neuromas and marfanoid features. So I actually think that this question would have been nicer if it was a little clearer, but this is the clue for him having Marfan syndrome. And these nodules that don't itch, don't do anything for him, are mucosal neuromas, okay? They can be on the tongue like this. So yeah, this is for this question, just to alert you how patients might present to you. And so what you do for this patient now, you test him for the RET gene. If you said RET gene, you're correct. This RET gene will tell you whether this patient might develop medullary thyroid cancer. And so before it even develops, you will have to remove it if it is there. Okay, here's the next question. Let's see the answer now. This is another case of multiple endocrine neoplasia, but this is a different kind. So here we have a patient with continuous upper abdominal pain, constipation, excess urination. The father has many stomach ulcers and multiple kidney stones, and the stools are positive for occult blood. Let's take this one by one. First of all, this patient, according to her labs and according to the clinical picture of constipation, excess urination, father having stones, this all goes with primary hyperparathyroidism, right? Okay, now she has a couple of other symptoms that are a little bit concerning, right? And so this patient has continuous upper abdominal pain. She has occult occult blood in her stool, and stomach ulcers. Okay, men one, remember, primary hyperparathyroidism, pituitary tumors, and pancreatic tumors, especially gastrinomas. So that's probably what's going on here. She has some kind of pancreatic or gastrinoma, maybe, pancreatic tumor or gastrinoma, and it is causing these upper abdominal symptoms. Now, I feel like we're mentioning GI a bit too much, and I'm sorry about that. But remember, the most common source of lower GI bleeding is upper GI bleeding, especially when it's occult blood like this. So most likely she's bleeding somewhere in her upper GI tract because of some kind of pancreatic tumor or gastric tumor, and it's causing this occult blood and the upper abdominal pain. Okay, so something else you might want to be on the lookout for in this patient is any tumor in her pituitary, right? And this is it for this question. We can move on to the next one. All right. So, what do you think this patient has, first of all? What is this lump in her neck? And why is calcitonin elevated? If you said medullary thyroid cancer, you are correct. This patient, unfortunately, most likely has medullary thyroid cancer. Now, medullary thyroid cancer is also part of men, multiple endocrine neoplasia, specifically types 2A and 2B. And 2A and 2B both have pheochromocytoma, right? You measured her blood pressure is normal. Does this rule out pheochromocytoma? If you said no, you are correct. It does not rule it out. What it does rule out is hyperaldosteronism. So basically, remember what Dr. Qabbani said, okay? You have a patient and they have hypertension, or you're testing their blood pressure and you want to see they have hypertension or not. If their blood pressure is normal, you just excluded any cause of renin and aldosterone being involved, okay? But if their blood pressure is high, then you might still be dealing with pheochromocytoma, you might still be dealing with aldosteronism, okay? Aldosterone being high. So this is an important learning point that the doctor stressed on. Now, since she has medullary thyroid cancer, I want to test her for pheochromocytoma. Her blood pressure being normal does not mean anything to me, so I am going to look at the metabolites of the pheochromocytoma, do a fractionated metanephrine assay, and see whether it's high or not, whether she might have pheochromocytoma or not. Okay, but it's not causing any symptoms. Why do I have to worry? She might still see here, she does not have pain, fever, night sweats, weight changes. She doesn't seem to have those symptoms. However, it might still be there. And if anyone operates on her for whatever reason, she might go into crisis. So you need to have this under control. You need to rule it out because it's life-threatening for the patient. Here's the next question. So let's look at the answer. If you chose D, then you are correct. So what we're dealing with here is an incidentaloma in the adrenal gland. You have a 52-year-old, she's coming for abdominal pain related to diverticulitis, and then during that, they discovered this, right? It wasn't causing any symptoms. And look here, it's 6.2 centimeters in diameter. Heterogeneous, smooth margins, etc, etc, etc. And now, what we care about here is, should we remove this? Should we not remove it? It's not causing any kinds of symptoms for her. She has no striae, no acne, no hirsutism, no bruising, no abnormal fat distribution, no proximal myopathy, no other findings. Medical history is absolutely unremarkable for anything. And when you test her, you see here when they tested her cortisol, it's normal. It was suppressed. If it's not suppressed, then you worry. Reading is fine, everything else is fine. So do you remove this mass or not? You look at what Dr. Qabbani told you guys. If you have a size more than 4 centimeters, there's a higher risk of it being cancer, remove it. If the Hounsfield units are less than 10, it's most likely to be benign. If it's more than 10, it's most likely to be malignant, so you remove it. I do want to answer one question that might come up. When you have an incidentaloma, you care about two things. Is it functional? And what's the size? Is it benign? Is it malignant from these features? Now, why do you care if it's functional? Why did they test for all of this, right? Let's say that this patient, for example, has Cushing, and we remove the tumor. What's going to happen after the patient comes out of the surgery if we just don't do anything? They might go into adrenal insufficiency, right? Crisis. Why? Because this tumor was secreting large amounts of cortisol. So it was suppressing the ACTH in the pituitary, and it was suppressing the other gland. And so if the patient comes out of the surgery and I don't give them some cortisol, some exogenous cortisol until they can kind of get, better, this patient might die, might go into adrenal insufficiency. So I have to be very, very careful with that. And so this is why we care whether it's functional or not. You want to know during the surgery, something might happen to the patient. Before the surgery, stabilize the patient. During the surgery, make sure nothing happens. After the surgery, make sure the patient stays okay. All right. And manage their symptoms depending on what they're missing and so on. But anyway, malignant feature, remove it. Okay. Here's the next question. So what do we think is going on with this patient? If you chose C, you are correct. This patient most likely has acromegaly. Everything. This patient literally has a textbook picture of acromegaly. Joint pain, finger swelling, can't grip objects. Maybe even he'll tell you that he tried to put a ring on and it didn't fit. His wedding ring, for example. He has poorly controlled hypertension. His blood pressure is high, and then he has coarse facial features. And everything with acromegaly, it's very important for you to compare before and after. Your wedding ring, you were able to wear it, now you can't. Okay, you looked one way in your driver's license 3 years ago, now you look completely different. His palms are sweaty, he has multiple skin tags, and he has this is for carpal tunnel, right? This is basically a positive sign of carpal tunnel. So what do we do? First thing we want to do is test insulin-like growth factor, okay? Because this is the guy that growth hormone goes to in the liver, and it does everything that growth hormone is supposed to do. Now, this is a, my goodness, sorry. This is a growth hormone following, this is basically a tolerance test. And you can do this test after you do the insulin-like growth factor. Because when you do insulin-like growth factor, you just tell the patient, go to the lab, get some blood work done, and then come back, okay? So the first thing you do, you're suspecting acromegaly. First thing you do, you check insulin-like growth factor. If it's normal, there's no acromegaly. If it's abnormal, then you make the patient undergo an oral glucose suppression test, right, which is B. And then again, if it's suppressed, there's no acromegaly. If it's not suppressed, then you go for D. You do an MRI of the brain, okay? And then after that, you decide how you want to manage the patient, medical, surgical, etc. Here's the next question. I'll give you a minute to read it and then we can answer. Okay, let's take a look. So if you answered C, you are correct. So what's going on with this patient? Let's see. This is a 66-year-old man. He's coming with nausea, loss of appetite, fatigue, and weakness. Now, when you look at his past medical history, he was taking prednisone daily for 12 months, and then he suddenly stopped it 7 days ago. And we know that when someone is taking steroids, especially high doses, especially for things like polymyalgia rheumatica, for example, or they are meant to taper them, right? You don't suddenly stop steroids because you risk patients going into adrenal insufficiency or adrenal crisis. Looking at the rest of the vignette, we have a patient looking like he has Cushing's because his face is round and plethoric, and there is excess supraclavicular fat deposition. Okay, now, why would this patient have decreased ACTH and decreased cortisol? When you take a lot of cortisol, either, for example, you have a tumor secreting a lot of cortisol, or you take it exogenously, you're suppressing the normal making of cortisol in your body. So the adrenal glands releasing cortisol would be suppressed, and ACTH in your pituitary would also be suppressed because they don't see any reason to be secreted since the blood already has plenty of cortisol in it. Now, when I suddenly stop this the cortisol coming into the body, either by suddenly removing a tumor, like over here, 1 second, where's that question? like here, for example, let's just say this patient has had Cushing, right, in his tumor, and I suddenly, like, well, not suddenly, but I remove this tumor from him, I remove this cortisol that's being secreted, he will go into adrenal insufficiency unless I give him the cortisol he needs until his body sort of understands that, okay, now we need to start secreting our own ACTH and our own cortisol, and we need to wake up from the deep slumber that we were in. And so this patient went into adrenal insufficiency because he suddenly stopped the exogenous cortisol while the adrenal glands and the ACTH in his body were still asleep. Okay? Okay. Here's the next question. Okay, let's see the answer. If you chose C, you're correct. So what's going on with this patient? He's a 35-year-old man. He's evaluated for poor exercise tolerance and muscle weakness, no past medical history. His blood pressure is very, very high, and his systolic, both systolic and diastolic, as you can see here. Here are his labs, and he has a 3-centimeter mass in the left adrenal gland. So look at his labs. He has hypokalemia. Okay, his sodium is a little bit high, and here's his glucose, his creatinine. So what does this patient have? You have a patient with hypertension and with hypokalemia. How are you going to evaluate this patient? Okay, either this patient is going to have high renin and high aldosterone, or this patient will have low renin and high aldosterone, or low renin and low aldosterone. If this patient has high renin, high aldosterone, and then this patient most likely has, for example, a renin-secreting tumor, or he has malignant hypertension, or he's using some kind of diuretic. But as you can see here, he does not have anything wrong with his kidney, but rather he has some mass in his adrenal gland. So this is most likely to be low renin, high aldosterone. Why? What's going on in this patient is that he probably has primary hyperaldosteronism, where you have aldosterone being really, really high, so it suppresses the renin. And that's it for this question. Now we're going to take repro questions. Also, just one more thing. The bicarb here is just compensating. So you have high bicarb because as a reaction to the potassium being really, really low. Okay, now we'll do repro questions. Just give me 1 second. Okay, now let's do the repro questions. So here's the first question. Now let's see the answer. So if you chose C, you are correct. Non-steroidal anti-inflammatory drugs. So what this patient is, she's a 15-year-old girl. She's coming for evaluation of her menstrual periods. Menarche was 3 years ago, initially irregular or heavy, non-painful, which is normal. Now it's regular, but recently she has been getting malaise and dizziness and continuous abdominal pain that radiates to her thighs. And after the second day of menses, everything goes well, and everything else, she's not sexually active. Everything else is fine with her. So what this patient has is dysmenorrhea. And the first thing you want to give for someone with dysmenorrhea and they're not sexually active or anything is just NSAIDs. You give them painkillers for as long as they need it. In her case, she might only need it for the first day, and we are done. And this is it for this question. One thing I want to comment on is copper-containing intrauterine device. IUDs can actually make dysmenorrhea worse, so we do not give them. And she has no need for her to take, for example, progestin pills like contraception. She doesn't need to take it because she's not sexually active, and NSAIDs are going to solve her problem. So the first line for someone with dysmenorrhea and no sexual activity is just NSAIDs. Here's the next question. Okay, let's look at the answer now. So if you said C, record daily symptoms for 2 consecutive days, you are correct. So basically, this patient most likely has premenstrual syndrome, PMS, okay? She has irritability, fatigue, bloating, and they're all worse 1 week before her menses, right? At other times, she said nothing really happens. The first thing you want to do is confirm, is this PMS or is it something else? And how can I confirm? The best thing I can do is record daily symptoms, and this actually is part of the diagnostic criteria for premenstrual syndrome. So the first thing you want to do is have any of these symptoms, your usual depression, anxiety, all of that, more of difficulty concentrating, lethargy, changes in appetite, etc., etc. They're all, I don't think they're very difficult to recognize on the exam. Then they have to interfere with social and occupational or sexual or scholastic functioning. They have to be, you know, things that affect the patient's life. When you tell the patient, how is this affecting your life? And she tells you, no, it's fine, I don't really care. Then she does not fulfill criterion B. Finally, criterion C, they have to be related to the menstrual cycle. And so you have to have daily ratings, at least 2 consecutive symptomatic menstrual cycles. Then I can say, okay, this might be PMS, and I might look into how I want to treat this. Okay. So, starting with lifestyle. Here's the next question. Okay, so let's read this scenario. This patient is a 15-year-old girl. She has irregular, heavy bleeding with passage of large clots. Passing clots is not normal. Some small clots is okay, it's normal. But large clots, and a lot of them with heavy bleeding, is abnormal, okay? Now, her menarche was 1 year ago, so it was quite recent. And everything else seems to be fine with this patient, okay? So they looked at the thyroid, they looked at her breast development, everything else is fine, along with her coagulation profile, okay? So now what do we want to do with this patient? In this patient, you want to start progesterone therapy. Why? This patient is most likely having anovulatory cycles. Look here, her menses occur at 2 to 4 month intervals. So for 2 to 4 months, she might not get her menses. And so what's going on during that period is that estrogen is being secreted. So basically when we ovulate, we have a corpus luteum staying in our ovaries for a while, secreting progesterone. And this progesterone will make our endometrium secretory, right? When we have estrogen, we have proliferative endometrium, and when we have a lot of estrogen being secreted, the endometrium is just getting thicker and thicker and thicker, eventually leading to heavy bleeding with passage of large clots. Okay, so we want to make her cycle regular. We want to give her the progesterone she's missing for a while until she finally has regular periods. Remember this question here? We said it's normal for her to initially have irregular heavy periods, okay? But just because something is normal doesn't mean that it's fine and we don't need to manage the patient's symptoms. For management of this patient's symptoms, we can give her progesterone, make her periods regular, till they eventually become regular on their own. Okay, and so what you want to give this patient is progesterone so that her proliferative endometrium becomes secretory and she can finally have regular periods. Okay, all of these are not indicated in someone who's this young and who recently had menarche. Okay, here's the next question. And now let's look at the answer. So if you chose B, you are correct. So what is happening with this patient? This patient is a 19-year-old. She's nulla gravida. She never gave birth. She never got pregnant. And today she's concerned because she thinks that the oral contraceptives she's taking are causing her weight gain. Okay. Now one thing to note is, first of all, before she took those oral contraceptives, she had heavy periods and severe cramping. So she had menorrhagia and she had dysmenorrhea. And she is sexually active, okay? And as you can see here, very important to note is that she uses condoms with her partners, but inconsistently. So, would you keep this patient on oral contraceptives or not? Number one, the weight gain is not related to oral contraceptives. Number two, the best thing you can do for this patient is keep her on oral contraceptives. Let's go through the options. The first one says, discontinue oral contraceptives and start her on NSAIDs. You might be thinking, okay, why not, right? She has severe cramping, dysmenorrhea, just give her NSAIDs and they'll do the job. You would be incorrect because this patient is most like, if this patient obviously desires contraception and she does not want to have kids right now, then oral contraceptives are the best, right? So in sexually active, contraceptive desiring patients, you give them OCPs, you do not give them NSAIDs for dysmenorrhea. Okay, next one, give them to a copper intrauterine device, IUD. Would you give that to someone who has dysmenorrhea? No, because it would make it worse. Giving her progesterone injections, that is not good for her at all, because what do they cause? Osteoporosis. She's so young, so giving her something like that would not help her at all. And giving her progesterone only pills is not going to help her dysmenorrhea. And it's not really like, if you have like a contraception ladder of best to worst, and progesterone is not very effective at contraception. So the best thing you can do is just reassure the patient weight gain is not related to your combined oral contraceptives. You can continue taking it. Which brings me to the next slide. This is very high yield. This is from Dr. Manaz's lecture last year. And I just thought that the table she made was really, really nice. So you can see here she has weight gain, has no evidence. The most important thing you guys need to keep in mind are the mild symptoms, nausea, vomiting, bloating, and then migraine. So if, for example, someone has migraines, very, very bad migraines, you don't want to give them oral contraceptives, okay? Another thing, most importantly, is that they give you, like they make you have a hypercoagulable state. So anyone with history of stroke, pulmonary embolism, DVT, etc., you don't give this to them. Someone who is a constant smoker, you don't give them. An absolute contraindication is to give them oral contraceptives, okay? And finally, this risk of cancer is also pretty relevant. It increases breast and cervical cancer, but it decreases endometrial and ovarian cancer risk. Okay, and now here's the next question. So if you chose A, you are correct. So I forgot to highlight the other things, but let's go through this scenario. So we have a 40-year-old woman, gravida 2, para 1. She's coming for her first prenatal visit, and she has a 10 weeks gestation, and she has no concerns, feels well, everything's fine. No chronic conditions, no medical conditions, no history, and she has a viable fetus. Okay, now what are we going to do besides the routine testing? We test for cell-free DNA. Okay, we already confirmed her pregnancy, so we don't need to do a beta HCG test. And these are not things that we regularly test for. So what we want to test for is Basically, this is something called non-invasive prenatal testing or cell-free fetal DNA. You want to test, does this child that the patient is carrying have aneuploidy? Does she have trisomy 21, trisomy 18, trisomy 13, etc.? So you do this non-invasive testing. You take some blood, you test it in the lab. Okay, this is just screening to see if the patient's child has any congenital malformations. Which brings me to this slide. So I noticed that your PowerPoint doesn't really have something like this. This is from KFSH. So we can go through it real quick. Preconception, you want to give the patient folic acid, make sure that they are immune to rubella and varicella or test them for it. Give them any vaccines that they're missing and control any symptoms that they have, okay? Now, most patients are going to come for their initial visit. This is called the booking visit at around 7 to 14 weeks. This is when they feel, that they have a child. And their first visit is going to have CBC, blood grouping, and antibody screening, because if the patient loses blood, etc., you want to know what to give her. Is she does she need ROGAM? Like, is she Rh negative or not, so that you prevent hemolytic disease of the newborn. You want to check whether she is diabetic. So you check diabetes twice. You check it here, and then you check it later on at 24 to 28 weeks. Where is it? Somewhere there. Oh, here it is. Okay. And then you also check for hepatitis. You check rubella, varicella, syphilis, HIV. Okay. You do not check cytomegalovirus. Next, you check if she has any problems with her thyroid, vitamin D levels, and urine culture, because even if the patient has asymptomatic bacteria, she can risk miscarriage or something like that. So we treat asymptomatic bacteria in women who are pregnant, okay? Meanwhile, normal women, you only treat if they're symptomatic. You also do the knuckle translucency, and here you can see NIPT, okay? Knuckle translucency and NIPT are both to check whether the patient potentially has any aneuploidy or trisomies, okay? Then 20 to 23 weeks, we do a detailed anatomy scan. This is around the second trimester. And then 24 to 28, this is the high yield for you, is to check whether she has gestational diabetes or not, okay? So we check her blood sugar once at the booking, and then again at 24 to 28 weeks, and then we repeat all these investigations. At 27 to 36, this is not really high yield for you, but they give Tdap injection. And then we do GBS. This is high yield at 36 to 38 weeks. Okay. So what's high yield for you to know is at booking, we need to check for blood sugar. We need to check TSH. We need to check only hepatitis, rubella, varicella, syphilis, and HIV. And I don't really think they're going to test you for these guys. Was scanning good to know. We have to treat asymptomatic bacteria in women. We have to make sure they don't have any UTI. And NIPT equals cell-free DNA testing. We do this with knuckle translucency at 11 to 14 weeks. GBS at 36 to 38. Diabetes, again, 24 to 28 weeks. Don't forget, okay? And this is the most high yield thing you need to know from this. Okay, here's the next question. Yep. So this patient, if you said D, placenta previa, you are correct. What's going on? What is placenta previa, first of all? Or no, let's look at what this patient has. She's a 34-year-old gravid at 4, para 2, aborted 1, and she's coming because of vaginal bleeding after intercourse. So basically there was some penetration and then she started to bleed, okay? Now, she woke up in a pool of blood, continues to soak, and she did not have routine prenatal care, but her ultrasound showed a singleton intrauterine pregnancy. And she just has one child. And she has previously had 2 cesarean deliveries at term. She smokes, and her fetal monitoring is fine. So you don't really need to know the details of this right now, but this means that the fetus is doing fine, okay? This is normal blood pulse, and accelerations means fine. Absent decelerations, absolutely great. Decelerations are not good. With moderate variability, great, okay? But you don't need to know the details of fetal monitoring. Like, she has irregular contractions, and she has a gravid non-tender uterus, which means she has painless vaginal bleeding. Okay, so what is the most likely cause of painless vaginal bleeding in a pregnant woman? It's most likely placenta previa. Okay, placenta previa is this. When the placenta is too close to the cervix, it can either be less than 2 centimeters close, or to the margin, or partially covering the opening, or completely covering it like this picture, okay? And this basically can cause vaginal bleeding, but it's painless, okay? Number one, painless. Number two, the fetus is fine, okay? The fetus heart rate, in other, for example, questions like, for example, placental abruption, when the placenta is like separating from the mother, the fetus would not be doing very well, right? But this mother has painless vaginal bleeding, so it's most likely to be placenta previa. Okay, when you go through an inevitable abortion and you look at the cervix, what's it going to be? It's going to be open, right? Because the products of conception are already coming out. Meanwhile, this patient has a closed cervix, so she's not going into birth, right? And complete hydatiform mole, basically this is an abnormal pregnancy. And in this situation, what you would see is there would not be a viable fetus in there, okay? There would be like a snowstorm appearance on ultrasound, but we can see here the patient's fetus is doing fine. It's a real alive fetus with a bumping heart, basically. Cervical insufficiency just means the cervix would be too short, but there is no mention of that here. And preterm labor, if someone's going into labor, their cervix would not be closed, okay? And they would be in pain. Like, this is placenta previa. Now let's go to the next question. Okay. If you said E, premature placental separation, you are correct. This is very, very similar to the question that we were reading before. But the difference here is that she has excruciating constant abdominal pain with her vaginal bleeding. And her blood pressure is very, very, very high. And her uterus is tender. And they look at the fetus. Look here, the fetus has bradycardia. So the normal fetal heart rate is 110 to 160. So this patient has some bradycardia and no variability, which is alarming. Again, I promise you don't really need to know what this means at the moment, but it helps, okay? And her cervical os is open. So what does this patient have? Placental abruption, okay? This is when we have separation of the placenta from the uterus. And it causes bleeding, and this compromises the fetus, okay? Implantation over the cervix, this is placenta previa, it would not be painful. What else? Disruption of the uterine wall, this is uterine, this is basically when the uterus, like it tears, and this is not what's going on here, because it would not be, let's see, it's firm and distended. If the uterus tears, it would not be firm and distended. You wouldn't really feel it anymore. Injury to the fetal placental vessels, this is vasa previa, which is, so this is here, tearing of the uterus, this is uterine rupture. Here's vasa previa. This is when the vessels in the umbilical cords are kind of exposed. So here the fetus would not be doing very well, and you would have bleeding, but it would not be so painful like this. Finally, attachment to the placenta to the myometrium. This is not something you need to know, but just for your information, this is called placenta accreta. If the patient has multiple, for example, cesarean sections, there would be scars in the uterus. And so when the placenta implants, it sticks too much to the uterine wall, causing placenta accreta. So basically, it would be difficult for you to deliver the placenta, as opposed to it abrupting and separating from the uterus. Here's the next question. So this ties into like one of the first questions I talked about. Okay, let's see the answer. So if you said C, serum FSH level, you are correct. What's happening for this patient, you might have guessed from the scenario, decreased libido, pain with intercourse, the pelvic examination shows like signs of atrophy. So she has scant pubic hair, the mucosa is pale, and she removed her uterus, so we don't really have any information about her menstrual cycle. This patient most likely might be undergoing menopause, right? And so to test for menopause, we can look at serum FSH. So remember we said LH, we look at it for PCOS because there's no ovulation. FSH, we look at it for menopause. Why? Because with menopause, there are follicles, right? And the follicles basically decrease. There's basically no more ovarian reserve. So the FSH is being secreted and it's looking for follicles to stimulate, but there are no follicles, right? Okay, so here's our next question. We have a 67-year-old woman. I'll give you a minute to solve this and then we can discuss it. So what's going on with this patient? If you said B, hysterectomy and bilateral sublingual you are correct. So this patient is 67 years old. So clearly she is, and she told you she had menopause at 56. So you would expect patients who are around this age to be menopausal. Okay, she's coming why? Because she has 2 months of intermittent vaginal spotting. This is called postmenopausal bleeding, and she is nulliparous. She has no children. Her BMI is high. She's at 32, which is basically puts her at obese. And when we do transvaginal ultrasonography, they basically put an ultrasound into the vagina. They know that she had endometrial thickness of 12 millimeters. This is very thick, okay? And when they did biopsy, they found hyperplasia with atypia, disorganized glandular tissue, and myometrial invasion. When you hear all these crazy words, you think, okay, this is probably cancer, okay? Postmenopausal bleeding for a little bit of time is okay, maybe because the patients, for example, have atrophy of their vagina, so it bleeds a little bit, and you give them estrogen cream. But with thickness like this, endometrial thickness, and these abnormal cells, hyperplasia with atypia, you are concerned for cancer. And this is called atypical hyperplasia, okay? Now, let's just look at this scenario a little closely. Why did this patient develop endometrial hyperplasia, which could possibly become endometrial cancer? Because of a couple of reasons. Number one, this patient had late menopause. 56 is pretty late. So this is one. Two, she has had no children. Three, her BMI is 32. She's obese. All of these things make her exposed to a lot of estrogen. So if you have late menopause or early menarche, you're exposed to estrogen more than the average person, right? Number two, having no children means you never got pregnant, right? Means that you had more estrogen being secreted when you have, compared to, for example, progesterone. And so this patient, again, more estrogen being secreted. Two, BMI is 32. And we know that when people are obese, what happens is something called peripheral conversion. So you have more estradiol, aka more estrogen, okay? Because the fat basically gets converted peripherally into estrogen. And so all of these factors make her more susceptible to having endometrial cancer because her endometrium is getting constantly exposed to estrogen. Estrogen causes proliferation of the endometrium, okay? And this is especially bad if, for example, you read in her history that, for example, she had breast cancer or breast cancer history in her family. Okay, so this is just a summary from Dr. Muna's lecture for postmenopausal bleeding. So most likely patients will have just atrophic vaginitis and you treat them with topical estrogen cream or estrogen pessaries. For polyps, you just remove those. And when you have hyperplasia, if it's simple hyperplasia, it's not atypical, you can give progesterone, okay? So here, they had high-dose progestin therapy, but she had atypical hyperplasia, not just any hyperplasia, which is why we opted to just remove everything and be safer, right? Okay, here's the next question. We're almost done. Now let's see the answer. So if you chose E, core needle biopsy, you are correct. So I did not find any like PowerPoint on breast lumps in your drives, but we did have them last year. And just in case, I bought you 2 questions. So this is one of them. So this patient is a 57-year-old nulliparous woman. Nulliparous, again, she never had children, just like this patient here, which means that she was exposed to more estrogen. And she noticed a lump in her breast. And she had menopause 5 years ago, and she was on HRT, hormone replacement therapy, because she had symptoms of menopause, like hot flashes and vaginal dryness. I think they did mammography, yep, and it shows non-circumscribed 2 centimeter mass adjacent to the nipple. What do you do? The patient was nulliparous, and she has a lump like this, and she's on HRT, which means she's being exposed to estrogen. You do a core needle biopsy. Okay, this is the standard. Fine needle aspiration is for cysts. Excisional biopsy means you open her up in the OR and remove the lymph nodes, which is too much for something that you can do in a much easier way. Ultrasound, so this is very important. You do ultrasound if the patient is less than 35. More than 35, you do mammography. And then finally, measurement of serum CA15-3. This is basically just the cancer marker of breast cancer. And you only use these for prognosis. You don't use them for diagnosis. So if you want to diagnose, you use a core needle biopsy. Big, thick needle, you pull out tissue and you look at it histopathologically. Like, here's the last question. Very similar to the one before. Okay, let's look at the answer now. So here, you can see she's 27. She has a breast lump. What do you do first? You do an ultrasound. You don't do a mammography, and you have not yet done ultrasound, so you don't jump to do a core needle biopsy, okay? And here we say that she has pretty alarming history. So she's a smoker, or she used to be a smoker, and she has history of ovarian cancer, and the palpation, it's rigid, it's firm, it's non-tender. It's a little bit alarming, right? It's unlikely. It could be benign, but it could also be malignant. And so we want to do an ultrasound just to stay on the safe side. If the ultrasound is suspicious, okay, then we can go for biopsy, okay? And there is no need to do gene testing before you even confirm that she has anything, right? So the first thing we do is the easiest, most non-invasive thing, which is ultrasound. And that's it. Thank you guys so much for watching this. And I really, 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 really hope it's helpful. I know that ENDREP Pro is 4 credit hours, which is alarming, but it's much, much easier than GI, for example. And inshallah, the questions should be easy. They should be a lot easier than the questions in this PowerPoint. So congratulations for getting through this. And I hope that we can see you next year in the hospital. If you need anything at all, please let me know. This is my email, or you can text me on my phone number. And and please scan this code because your feedback is very, very helpful. And thank you so much.